Good afternoon. I'm Chris Fanta. It's my pleasure to welcome you to Asthma Grand Rounds today. And because it's the last of the academic season, I thought I might take a minute and share with you the schedule for next year's program. And here it is on display, and I think it's going to be a terrific year. We invited Melissa Suter from the Mass General to talk about her work on optical coherence tomography. Jeff Drazen will give an overview of asthma research, past, present, and future. Dr. Boyce is going to explain the mechanisms of aspirin-exacerbated respiratory disease. Adnan Majid from Beth Israel Deaconess Medical Center is going to come and talk to us about tracheobronchomalacia in the adult. And then we'll end with a discussion of, by ENT and allergy, of medical and surgical management of rhinosinusitis and nasal polyposis. So I'm looking forward to an exciting year. And I just want to remind those of you, I'm so sorry, who are joining us today by live webcasting, if you'd like to submit a question to be addressed to our speaker at the end of the program, jot down this number and text your question, and we'll address it to Dr. Raby. So with that introduction, I am delighted to introduce as our speaker today Dr. Benjamin Raby, who is a member of the Pulmonary and Critical Care Division at the Brigham and Women's Hospital, and member of the Channing Division of Network Medicine. He is the founder and director of our Pulmonary Genetics Clinic here at the Brigham and Women's Hospital, and is the future chief of pulmonary medicine at Boston Children's Hospital come July. And we're delighted, while you're still here, to have you talk to us about primary ciliary dyskinesia. Dr. Raby.
I certainly hope that doesn't imply that I'm not going to be invited back after July. But. Okay, so enough of this nonsense. So what was Chris thinking? Why are we possibly talking about this today? So I actually think it's an inspired idea in a lot of ways. And I have two examples to illustrate why. And I just want to take this opportunity, if we don't have time towards the end, to thank everybody for coming, and to all the people who've helped make the Pulmonary Genetics Center a success, to making our work in PCD a success, and that runs the gamut from all the people who are doing the clinical work and the organization to the research as well. And of course, special thanks to inviting me here today. So this is actually a patient who I saw in my first month of fellowship back at McGill. This is a real case of a 38-year-old woman who was admitted to the high-risk maternity ward with a severe asthma exacerbation. And when we saw her, I was not entirely clear why she was admitted to the maternity ward. She wasn't, so sick that she needed to be in ICU, and if she was, she should have been there, and otherwise, she could have easily been on a medical ward. But in fact, the reason that she was on the high-risk obstetrics ward was because she was very fragile when it came to becoming pregnant, and had to go through multiple rounds of in vitro fertilization, and so they were taking special care of her during this asthma exacerbation. And so I went in to see her, and because I was a first-month fellow, I was particularly eager to get a very comprehensive history. So I knew about her infertility, and then she gave me the greatest family history I had ever heard. And it was, I asked the question, by any chance, does anybody in your family have any of their organs on the wrong side of their body? And she said, my brother does. And so this is a patient with in fact, not severe asthma, but with undiagnosed primary ciliary dyskinesia. And the reason that she was infertile was because of the motile cilia along the fallopian tubes. This is another patient. So this is a 69-year-old woman who had a long-standing history of childhood asthma and then recurrent pneumonia starting in her teens, and had a complicated pneumonia with an empyema, underwent vats to drain the pleural space, and they lacerated a pulmonary vein in the process, and so she had to undergo a total pneumonectomy, and so that's why she has no left lung. And she came to see us at age 69 with progressive bronchiectasis, and her whole life had been labeled as an asthmatic. And as you can see, she has more restrictive physiology, she has a relatively normal IgE, and we suspected that this potentially was a case of PCD, actually, because she had a symptom of chronic nasal congestion forever. And in fact, she had 2 pathogenic mutations, the same mutation. She was homozygous for this very interesting, well-described splice mutation in a gene in one of the radial spokehead proteins. And it causes a milder form of PCD, explaining why a 70-year-old had made it this far with only 1 lung in this disease. But now this is the second case that I'm showing you where history of asthma was the predominant diagnosis early on. So in fact, 32% of children who will eventually be diagnosed with the diagnosis of PCD originally get a label of asthma. And often it's a difficult to treat asthma, and often it's a neutrophilic asthma. In fact, this number is definitely an underestimate. I know of very few adults who come in who we make a diagnosis who didn't have a diagnosis of asthma. And the only kids who probably don't get that diagnosis at some point are the ones who are diagnosed at birth because they're reversed. Exactly. So I think this is a much bigger problem than we understand it to be. So what I'd like to do is go through the clinical presentation, pathophysiology, and some diagnostic and management issues, but I want to begin by busting a few myths. So the first thing I want to do is make sure we're all on the same page here. So primary ciliary dyskinesia is a recessive genetic disease. It's almost always autosomal recessive, but there is an X-linked form. It's very rare. And it's always caused by loss of function mutations in one of at least 35 genes that have been mapped to date in this disorder. So we still consider it a monogenic disease in that you need mutations in one gene to confer the phenotype, even though there are 35 different genes that have been attributed as causal to this disorder. And all of them have in common that the loss of function results in an inability to properly either form or function the motile cilia that line the respiratory epithelium and the epithelium of the cyno-otic tracts and that of the reproductive system. So, myth 1, the physiological consequences of PCD are mild. We hear all the time that PCD is the milder form of CF. First of all, it drives the patients with PCD crazy to hear anything about CF. Particularly now, by the way, this is actually a very interesting evolution. As there are new drugs for CF that are really starting to make a major difference, the PCD community feels like they've been completely left behind and are really upset about the fact that there is no treatment for this disorder yet. Now, it is true, although the PCD Foundation may not want me to say this, that the mortality rates are certainly nowhere near that of cystic fibrosis. There's a considerable impact on pulmonary function and morbidity and quality of life. And so these are just 2 examples to illustrate that this is a progressive problem. It's not that one is born with some bronchiectasis and it's fixed like that for life. On average, people with PCD have an FEV1 that's at least 1 standard deviation below average for their age. And you can see on the right-hand side that CT scores of correlating with the severity of bronchiectasis get progressively worse with age. And this then translates into problems with gas exchange. This is a second paper showing on the left-hand side essentially the exact same information I showed you before, but it's in a longitudinal cohort of 27 individuals. On the right-hand side is the hypoxemia and hypercarbia that results in these patients progressively over time. Transplantation is not as frequent in these patients as it is in the CF population, but it does occur. It represents, I think, about 2% of transplants. So myth number 2, most patients with PCD will have the classic triad of bronchiectasis, infertility, and dextrocardia, which was what Cartaginer termed as his syndrome, the Cartaginer syndrome, having this triad. So in the textbooks and when you think about PCD, everybody thinks about this triad. But in fact, we don't see this in the majority of patients. Dextrocardia is only observed in 45%, and infertility is only seen in half of the women. So the likelihood of having all three, almost all adults will, in fact, all adults have to have bronchiectasis as part of their presentation. It's exceedingly rare not to see bronchiectasis in someone who's an adult with immotile cilia syndrome. But the other two do not necessarily have to be there. Third myth, and this is something that I only learned relatively recently in my career, is that dextrocardia is synonymous with PCD. Right? Whenever I think of dextrocardia, I think that the patient is going to likely have immotile cilia. But in fact, the incidence of dextrocardia is 4 times greater than that of PCD. So in fact, another way of saying it is that only 1 in 4 patients with dextrocardia will actually have PCD. And more importantly, only 50% of the patients with PCD would have dextrocardia, and I'll explain why that is later. So therefore, the incidence of dextrocardia is 8-fold that could be explained if it was all from PCD. So the vast majority of dextrocardia is not associated with this at all. Okay, so having said that, let's talk a little bit about the clinical manifestations. So again, a lot of people think that it's very similar to CF, and really the ways in which it's similar to CF is that you get progressive bronchiectasis, sinopulmonary disease, and infertility. And that's where the similarities really end. There are some fundamental aspects of PCD physiology that really play out in the presentation very nicely. The first is that the overwhelming majority of children who are diagnosed with PCD will have a history of unexplained respiratory distress within the first 24 hours post-delivery. In many cases, it's within the first 12 hours. It could be something as simple as tachypnea of the newborn, which is very vague, but specifically, most of these patients will have a radiograph showing lobar collapse, or that they required BiPAP, CPAP for at least 24 hours, or that they required high-flow oxygen. So it's not just a matter that they were tachypnic. It usually results in a delay of stay in hospital for an extra 12 to 24 hours, and you can elicit that relatively proximal. In the adult population, it's obviously harder to elicit that, but you'd be surprised how many patients I actually get that story from, that they were born at term, but they always knew that their mom was really scared in the first day or two after they were born and they had to stay in hospital longer. No one knew why. And the explanation is thought to be that unlike in cystic fibrosis, where the lungs are pristine when the child is born, and mucociliary clearance is actually not a problem right away in cystic fibrosis, the ciliary dysfunction immediately results in an inability to clear amnion properly. And so the respiratory distress in the first 24 hours is actually some ARDS or potentially some lobar collapse from the residual amniotic fluid that's not cleared properly. So that should be seen in a vast majority of patients. The other thing that distinguishes PCD from CF, but also from other pulmonary diseases in general, is a description by the mom that from the day the child is born, they are congested in the nose. It's just always running. And that congestion then goes on for life. They never have a day. They might not have sinus congestion, but they always have a runny nose. They're a snotty kid always. And it goes into adulthood as well. And then the other respiratory manifestations are quite similar to cystic fibrosis in terms of developing recurrent infection, productive sputum, and as the bronchiectasis gets worse, this gets worse and more predominant. With respect to the sinus disease is very much indistinguishable from cystic fibrosis. It's very hard to make any heads or tails that one patient might have one over the other. But where there's a huge difference is actually the ears. They are filled with pus. The rate of infection, of recurrent infection of otitis media is much higher, and the prevalence of auditory dysfunction and the development of deafness is much, much greater. I would say at least 50% of the adults that I see have a hearing abnormality. Some of them come in with AIDS, some of them were making the diagnosis. There's this thing called glue ear where it's just like impacted with all kinds of pus. the kids who get the tubes, the stomies put in to alleviate the pressure and improve the drainage, for weeks will have pus draining down their face. Okay, so it's a very extreme form of what you might see in cystic fibrosis. So the bronchiectasis, these are the typical features of bronchiectasis. The pulmonary function tests are similar to those seen in bronchiectasis. They can be relatively normal at the beginning. There could be a mild diffusion impairment because of air trapping, and then you can develop obstruction or restriction. The pathophysiology of the bronchiectasis is pretty well understood. We begin with impaired mucociliary clearance, and that results in recurrent infection, chronic inflammation, and then there's a loss of the integrity of the wall of the airway, both the epithelium but also the rigidity. That leads to ineffective cough, dilated airways, and then that further worsens the impaired mucociliary clearance. As I'll discuss briefly later, a major difference between CF and PCD is that in PCD, the primary issue is the cilia. It's not the mucus. And so the viscoelastic properties of the mucus are very different in CF compared to PCD, such that in CF, and this is actually one of the reasons why CF is so much worse, in CF, even with cough, it is very difficult to clear. Whereas in PCD, if you cough, you get things past where the cilia do their stuff, and the large airways can then expectorate the sputum. So, in fact, mucociliary clearance techniques work even better in PCD than they do in cystic fibrosis. Okay, so now let's break for a minute to talk about the pathophysiology, and then we'll go back to some of the clinical presentation as the genotype and the anatomy starts making a difference here. So, when we think about the primary cilia, or I should say the motile cilia, we're talking about what's called the 9-and-2 configuration. So if we look at a cross-section of the cilia on the epithelial surface after it's passed over the plane of the epithelial membrane, we see this 9-and-2 configuration of these doublet microtubules, these two circles, 9 pairs of them, and then in the center there's a central microtubule, okay? The duplets are connected to each other by something called nexin, and then there are these inner and outer dynein arms, okay, that actually are part of the muscle of the rotational aspect of the cilia. There are spoke heads that connect the outer dynein duplets to the central microtubule. You'll notice that in the cytoplasmic side of the cilia, the structure is very different. Okay, this is called the basal body, and it has a different type of organization. And interestingly, I haven't really seen a lot of discussion in the literature about the effects of mutation on the basal body structure. Everything really describes what's going on up here. So, as a result of dysfunction of one of the elements, or more of the elements here, we get an impairment in function of the cilia. They just can't do their job properly. And in fact, it's this defect that is the driving force behind the respiratory dysfunction that we see in these patients. So if we look here at a lung clearance index score, the higher the score, the worse the clearance is. That the score is a reflection of how much time it takes to clear a gas out of the lung. You can see that as the score increases, lung function gets worse. And you can see these are normal subjects, and the triangles are all the subjects with PCD. Similarly, that score is highly correlated with the bad CF CT scores, bronchiectasis scores. So clearance is what is important here, and maximizing clearance is the key to preventing respiratory decline in these patients. So I mentioned a lot about the sinus disease before, so I'm not going to go over it again. We then get on to the fertility issues. So classically, it has been said that 100% of males with PCD are infertile, and only 50% of women with PCD are infertile, and that ectopic pregnancy is very common in females. Why? Because the flagella of the sperm, okay, follows the same type of anatomy as the cilia, it uses the same genetic architecture, and so the flagella don't work well, the sperm just don't swim very well. The sperm themselves have perfectly normal DNA, of course, with the exception of the mutations in the PCD gene. And if you could take that sperm and use it for in vitro fertilization, there's no reason that you couldn't have a perfectly normal child. So it's just a matter of getting the sperm out. And in fact, this is what we do in these patients. For the females, the issue is the cilia along the fallopian tubes. And so if the ova cannot travel properly to the uterus, you get a high rate of ectopics and also a lot of malconception. But it turns out that the numbers are not what we thought they were. So in a very recent study, looking at around 40 women and about 50 males, it actually turns out that while the numbers in females are about right, that it's about a 50% infertility rate of spontaneous fertility issues, for spontaneous, it's only about it's a 60% infertility rate. But then if you then use in vitro fertilization, you can get the fertility rates above 50%. For males, up to 25% of males can spontaneously conceive a child. So one of the things that's really important is as kids become teenagers, become young adults, the males think that they're in the clear in terms of protection and so on. And we make it really clear to them, you're not off the hook. There's no free lunch here. So, and that goes obviously without saying about it. It has nothing to do with preventing infectious disease. So it turns out that now we think that it's about a 75% infertility rate, but again, with in vitro fertilization, we can increase that to about 50% successful conceptions. Now, what's important here is there seem to be correlations between the rates of fertility and the types of mutations in the structures that are abnormal. And I won't go into the details about it, but the bottom line is that if the structure of the cilia looks to be intact and it's more of a functional issue, there's actually a higher rate of fertility. Okay. Then the last thing is the heterotaxy, the dextrocardia, and congenital heart disease. So this is something that really differentiates PCD from CF. So we're going to go over why this happens in a bit more detail, but to make a long story short, the cilia are really important embryologically for differentiating right and left, okay? And so these cilia in the embryo are going like this back and forth, and they're making sure that the body understands the differentiation of right and left. And so the organs should go to the right place. The heart should rotate to the left side, the liver should end up on the right, spleen on the left, stomach on the left. When the cilia aren't working, it then becomes a coin flip. And so that's why among PCD patients in general, only 50% of them will have dextrocardia, because in the other 50%, the coin flip went towards a normal direction of formation, okay? But things actually get a bit more complicated than this, because it was observed several years ago that the prevalence of PCD mutations among patients with structural heart defects was very high. And if you look at patients with PCD, they have other structural heart defects other than just dextrocardia, things like cushion defects, so ASDs, VSDs, malposition of a vessel, at a much higher rate, 200-fold that of the general population. And then we get into a problem of something called situs ambiguus, which I'll discuss in a moment, and that has really devastating consequences. Other interesting phenotypes include pectus excavatum, scoliosis, and then there's some other associations that, frankly, they are really case reports more than anything else. So heterotaxy. So some vocabulary here. So situs solitus. Most of us, if not all of us in this room and on the web, are going to be situs solitus. Everything is in the quote-unquote normal position, as I described before. Then there's situs inversus totalis, where there's complete flipping of right-left differentiation. So the heart now is rotated to the right, and the liver is on the left, and the spleen is on the right, and so on. We see that here. And then there's situs ambiguus. And in this particular example of situs ambiguus, we have the organs flipped in the belly, but the heart is not rotated completely. These patients have major problems. The majority of them have malposition of the great vessels and end up having to require multiple surgeries to correct that. I have a really incredible example in a family of 3 patients with the exact same mutation, right? They inherited 1 copy of the mutation from mom, 1 from dad. They all were unlucky enough to get this disorder. One daughter has situs inversus totalis, and she has very severe pulmonary disease as well. The other has situs solidus and has actually mild pulmonary disease. And there's not really much of a connection, by the way, between having situs inversus and the pulmonary disease. There shouldn't really be any relationship there. But both of them are alive and well in their 30s. The third sibling, who had situs ambiguus, died at age 16, and not of pulmonary complications, but rather of the cardiovascular complications. Here's another example of where you've got the heart flipped, the spleen and the liver flipped, and this is a clear case of situs inversus, whereas here we have the heart is on pretty much the correct side, and the spleen is the only thing that's moved over. So here you have a case where the liver is still in the correct spot. Not the spleen, the stomach, the gastric bubble is in the wrong place. The spleen is actually still in the correct spot. So here's an example of where there's only one organ. Another thing that we commonly see is polysplenia, so multiple spleens all over the place. Okay, so again, why does this happen? Well, there are 3 different types of cilia. There's something called the primary cilia, and this is often very distracting for people. Primary ciliary dyskinesia means that the ciliary dyskinesia is primary. It's a genetic disorder, not that it's a disorder of the primary cilia. Totally ridiculous. Because there are secondary forms of ciliary dyskinesia, smoke-induced, inflammation-induced, and the like. But the real distinction is in the motile forms of cilia, of which there are 2. There's the embryonic form, and there's the form that's seen in mature cells in the respiratory epithelium, the reproductive tract. So the anatomy I described to you before is that of the mature, adult, postnatal cilia, whereas the embryonic cilia lack the central tubules and the radial spoke heads. And this has a very important genotype-phenotype correlation. If you have mutations in the genes that affect the central apparatus or the spoke heads, then there's no impact on this form of the cilia because they don't express those genes. So none of those patients will have right-left differentiation problems because all of those embryonic cells are working perfectly. It's only when there's problems in the dynein arms or in the nexin or in the total assembly of the cilia where you see that problem. So in fact, situs inversus is seen in less than 50%. It's about 45% of cases of PCD. Okay. So now on to a brief discussion about the genetics. And we actually don't have to go into great depth here. One could give a talk about each one of these genes and the way in which they were discovered and a lot of interesting biology. But the truth is the important thing to recognize is where these genes possibly can affect the structure and how that'll impact how we make a diagnosis, and some few examples of how they relate to clinical presentation. So if we organize this anatomically, we can think about the outer dynein arm, okay, which is over here, and you can see it on EM right over here. The most commonly mutated genes are in the outer dynein arm, okay? And until recently, I wasn't quite sure why that is, but it turns out that from that study of the fertility rates, patients who have outer dynein arm mutations tend to be more fertile than men. And so you can see how these variants will propagate in the population and will be under less selective pressure. And so they reach a higher frequency. And so therefore, these types of mutations are more prevalent than the ones that almost always cause infertility in half the population, okay? So the outer dynein arms, DNA I1 and DNA H5 are the 2 most commonly mutated genes. They represent about 15–20% of the cases. And then all the other ones represent a very small proportion each. So you've got inner dynein arm mutations that were identified. We've got a whole bunch that cause mixed problems of both the outer and the inner. And a lot of these proteins are actually assembly-related proteins. They're not structurally present in the cilia, but they help chaperone the proteins that go to make the cilia. So they're kind of the builders. Then we have a few that are related to the nexin. some that are related to the microtubules. Usually those are associated with the mixed. And then you have the normal ultrastructure ones. And these, if you have mutations in these, the EMs will almost always be normal. And so you would be, quote unquote, excluding a diagnosis of PCD based on the EM alone, which used to be the gold standard. So there are some genotype-phenotype correlations. I've mentioned some of these already. I've mentioned about the heterotaxy. Infertility, the outer dining, I didn't write this, but yeah, the outer dining arms related ones tend to have better fertility, and the radial spoke head mutations tend to also lead to higher rates of fertility. The most interesting is the radial spoke heads with respect to lung function. I showed you a patient already who had mutations in one of the radial spoke head genes, 70-year-old, living off of one lung and doing very well. Her bronchiectasis has not really progressed very much. Most of the patients with radial spoke head abnormalities have FEV1s in adulthood that are much higher than the rest of the PCD population. These are some of the hardest patients to actually diagnose. As I'll show you soon, some of the other modalities to try and diagnose them also fall short. So you really have to have a very high level of suspicion here, and this is where I think sequencing as a frontline modality is going to end up being very important. Importantly, there really are no relationships between the genotype and the bronchiectasis phenotypes. Okay, so diagnosis is a serious problem. We've already talked about the misclassification and the delay in diagnosis with severe asthma, but I want to show you some other data. What's really nice when you talk about a genetic disease is by using Hardy-Weinberg equilibrium and some population genetics formulas, you can actually predict what the prevalence of the disease will be simply by knowing what the allele frequency or carrier rates are of the mutations in the population. Okay? So if we look at cystic fibrosis, we know that 1 in 29 Caucasians will be a carrier of a CF mutation. You need 2 carriers to mate. So the probability of that is simply this squared. And then only 1 in every 4 of those births will be a passing on of the recessive mutated gene in both cases. So you end up with a live birth rate of this for cystic fibrosis. And so if we assume 4 million live births in the United States, you get about 1,200 new cases, and this is actually reality. There are 1,200 new cases of CF every year. For PCD, we know that if you take all the mutations in the different genes, okay, we end up with a rate that's about 50% that. Okay, but because we have to square everything, we end up with a rate that's only about 1/5 of what you would see in cystic fibrosis. So it's estimated that we should see for every 5 CFs, 1 PCD. But in fact, that is not the case. So this is what we should be seeing. Based on these numbers, there are 30,000 people in the United States right now with cystic fibrosis, and there should be 6,650 people with PCD. But in fact, we know of only about 3,000, of which, by the way, only about 1,500 of them are conclusively diagnosed based on a full evaluation. So just on that basis, there's a missing group of patients. At least 50% of the patients are missing from being diagnosed, okay? But more than that, the survival rates are higher than in CF. So in fact, the population prevalence should be higher, and it's estimated that there are actually about 15,000 people in the United States who have PCD. And yet we're adults, not children, but by the time they get to adulthood. And so we're missing a lot of cases. And now, in the next few slides, you will see why. It's not easy to make the diagnosis. So official recommendations say that you need to have both phenotypic presentation with a confirmed laboratory test. You'll see that there's problems on both sides. So if we look at the most prevalent symptoms of the disorder, okay, I talked to you about the unexplained respiratory distress of the newborn. We discussed the snottiness and the nasal congestion, and then there's the laterality defects. Now, with the exception of the laterality defects, all of you will recognize that the others are relatively nonspecific, right? We see snotty kids all the time. And if we diagnosed everybody who was a snotty kid with PCD, the PCD Foundation would be the CF Foundation. But that's not the case. So people started looking at composites of these. How many do you need to make a diagnosis? So as we increase the number of these major criteria, we increase the specificity. We stop missing we start being very accurate in who we identify. But what drops like a stone is our ability to detect these cases. So people are starting to be trained to look for situs inversus and bronchiectasis and snotty nose and so on. If you're looking for many of these things, you're actually going to miss a lot of the cases. So there's got to be this balance between thinking everybody in the world has PCD and missing the majority of the cases. And what we need is a non-invasive test to make this happen that's readily accessible. Well, up until recently, the only test that people did on a relative basis, on a relatively common basis, was EM. So you do a biopsy of the nasal mucosa, and then you do electron microscopy. You need someone who's highly specialized in this technique. And what's now emerged, and I'll show you some data, you need someone who really knows what they're looking at. And because no one sees a lot of cases, there are very few people that are really experienced in looking for this. And you look for different types of defects. So here you can see the outer arms are missing, but the inner arms are preserved. Here you can see the inner arms are present, but the outer arms are preserved. Here's a mixed problem. Here's a central apparatus problem. I actually really love the way the central apparatus problems look. It's crazy. Sometimes there's no central apparatus. Sometimes there's 5 of them in one cell. It's really disordered. And then there's a huge number of cases, up to 30% of cases now, that it's completely normal structure. Now, there's some good genotype-phenotype correlation here. I've described this here. But even if we characterize all these, we're still missing the genes in about 30% of the cases as well. Now, here is what has happened over the years. So if we think back to 2000, we really didn't know of many genes. I think there was 1 gene mapped in 2001 for PCD. So at that time, the way you made a diagnosis was really you needed family members, and they needed to have the constellation of symptoms that you'd feel secure enough in making the diagnosis. So really, the EM ended up becoming the gold standard of making the diagnosis. And so at that time, if you're saying you have to see abnormalities on the EM to be called a PCD case, then EM is going to have a really high sensitivity and specificity. But over the years, we've now mapped 35 genes that explain 70% of cases. And this is what's happened to the sensitivity. And it continues to fall. In fact, it's now almost a coin flip as to whether or not the EM is going to help you make the diagnosis or not. And because so few places do it properly, and because it's a relatively invasive test, fewer and fewer people are doing it. And some people are just making empiric diagnoses of PCD based on a snotty kid with recurrent infections, and they don't really have any other explanation because their immunoglobulins are normal. And that's not acceptable because we know the majority of those kids won't have PCD. So the problem is not only on the sensitivity, it's also on the side of the specificity. So there is the MCC, the Mucociliary Clearance Consortium. And they are a great organized group that have kind of coalesced around both cystic fibrosis and PCD. And they did a retrospective study. They found 153 subjects that had a positive EM from different centers around the United States. They brought 3 expert reviewers to review all of these EMs. And of those, 75% of them were confirmed to, in fact, have the hallmark features of PCD on this EM. But of these ones that were all positive, 25% of them actually had normal ciliary ultrastructure on review by these 3 experts. Okay? And of those, only 2 of them ended up having a confirmed diagnosis by genetics. The others had no genotype. And another fraction had what looked to be, by other supportive evidence, that they probably had PCD. But there's still a whole 18% where they had what was thought to be a positive EM initially, and they don't really have PCD. So the field is moving away from using EM. It's still there, but there are other modalities. So the big one is nasal nitric oxide. So this is different than exhaled nitric oxide from the airways. This is specifically isolating the sinus space, isolating that from the respiratory tract, and measuring in a dynamic way the production of nasal nitric oxide from the sinuses and the paranasal sinuses. And in normal individuals, the production should be greater than 300 parts per billion. It should be like 500, 600, 800 parts per billion. The cutoff in nanograms per deciliter, which is what a lot of people are using now, is 77. Most of us in this room would have in the 200s. Okay? an initial study suggested that a cutoff of about 77 was really quite discriminatory. And here's the data from the initial study. So they look at a whole bunch of people who have PCD, compared them to normals, and then compared them to people who were referred for PCD, but were referred for something, but they thought it wasn't PCD. And then these are the people who were suspected of having PCD, but ended up not having PCD. And then this is the cystic fibrosis group. And so there's a lot of things that emerged from this first study. Some of them weren't really as well appreciated at first pass. The first is that it is pretty good at differentiating from normal subjects. But when it comes to differentiating from people with a related disease that actually is the phenotype you're trying distinguishing from, there's a number of patients where it just doesn't do quite as well. And importantly, there was this one subject who had definite PCD, who's way up here, and one or two other patients that also probably would fall into the normal category. So first, dealing with some of the false negatives, things that are too low even though they don't have false positives. So the big one to remember is nosebleeds, because heme binds the nitric oxide. And so if you've had a recent nosebleed, your NO is going to be low. Also, if you have chronic congestion that your sinuses are completely blocked off, the probe is not going to be measuring your paranasal sinus NO production. Recent viral infection, and then finally cystic fibrosis. Most of you can see the problem here. What are we trying to differentiate PCD from in a lot of these cases? It's these other diagnoses. So this is a point of a little bit of contention, and you'll see how this ends up playing out. So following that initial study, there was then this second, much larger study of a considerably higher number of patients across a broad age range. And you can see that for the most part, the NO really does very well at differentiating from healthy controls. Again, there's no CF here, and that's where the real issue is, and also chronic sinusitis in general. But you can see in early childhood, there's some that are missed. And so it's not recommended to use nasal nitric oxide in children less than 5 years of age. It just is not reliable. What I'm not showing you here, but I will show you now, is the patients with radial spoke head mutations. They're an amazing group of patients. So like I said, they have relatively preserved lung function. A lot of them have normal fertility, okay? And now you do the nasal nitric oxide, and it's hugging the line, and in some cases, totally normal. Very difficult group to diagnose. Very challenging. Okay, so now, superimposed on that table I showed you before, this is the general thought about nasal nitric oxide levels. And this is once you've done a sweat chloride test. So if the sweat chloride test is normal and the exhaled nitric oxide is very low, and they haven't recently had a nosebleed and they're not really super congested at the time you do it, you can feel pretty confident. But it's still not 100%. This is then a real-world example that emerged after that, and you can see it doesn't perform as well as that original study. It's still pretty good, but you're going to be missing 10% on both sides. So making this diagnosis requires diligence, persistence. It's not always easy. This is just to remind you about the sweat chloride. Okay, so to conclude about nasal nitric oxide, it's really easy to use. You stick the probe up the nose and you get them to breathe through a closed velum. So you just have them breathe against something with resistance. It closes off that. You measure the static pressure. It's really not difficult to do. The problem is it's not really easy to get access to it. You guys all have access to it here because we have one. But it's not an FDA-approved instrument, and therefore it's not reimbursable, and therefore almost nobody buys one. Because it's 50 grand to do it, you have to have somebody upkeep it, and so no one thinks it's worth the expense. We use it for research purposes. We have to, because it's not FDA approved, we have to consent every patient to get the measurements, but we get the measurements on all our patients. The sensitivity is pretty good, but it misses a few things, and the specificity is pretty good, except for the problem, as I mentioned earlier, that the things we're trying to differentiate are often confused. Here's data that's been collected by our team. Katie Dong led this work. And so this is our initial real-world experience using nasal NO in our patients. These are all adults. So we had cases that we knew had PCD. They had 2 pathogenic mutations and had clear features of the disease, all of them had levels that were below the cutoff of 77. These were all the people who came in for referrals for idiopathic bronchiectasis, who we were very confident in excluding PCD on a number of criteria. In some cases, we have a very specific alternative diagnosis. And you could see, with the exception of this patient, we did a great job. Okay? This patient had a very blocked nose. We were planning on repeating it. We haven't done that yet. And then there's these 4 patients. So we don't know what's going on with these 4 patients, except to say this. Here's the first one. This patient has no cilia. They have none. So they don't even have any of the pathology that was described. They are acylic. So they have something, and we just don't know what it is yet. What's interesting is he's got a dysmorphic set of features as well. So we did a karyotyping, and then we did an array CGH, and we can't find a deletion or a copy number variation that would explain his disease. So we're still working on him. Then we've got this person who's genotype positive. So we think he is a false negative. He should have been in this category. Okay, fine. So we have our first true false negative. Then we've got this patient. We're going to come back to her later, but she's hugging the line. She has a brother who has exactly the same phenotype as she does, so this is a heritable thing. She's had sequencing up the wazoo, and we cannot find any pathogenic variants. So we think she's a possible case that is yet unmapped. And then there's my favorite. He's got the triad, but he's got no pathogenic genotype. And he's got the highest level we've ever measured. Like, there's nobody in this room who has a level like this. We've brought him back and repeated it 3 times. So we think at the end of the day that he and she have something new that we're going to be able to describe eventually if we continue the hunt. And so we're doing a lot of mapping in them. Okay, so that's what I have to say about nasal nitric oxide. So you can see it's helpful. We all have access to it here. Those of you remotely, feel free to send your patients to the Pulmonary Genetics Center, and we have the official PCD Foundation designation as a center of excellence, particularly because we have the nasal nitric oxide and can do this. So feel free to send patients. It's a non-invasive test, and we get the answer pretty quickly. Other modalities. So this is probably going to become a very important modality, and that is immunofluorescence, in situ hybridization, or antibody-based testing, looking for specific proteins that make up the cilia. And so you can see in a case where you have a normal ciliary structure, you have a stain for a component of the cilia that you don't think is going to be altered, that should always be there, and then you have a specific protein that you think might be absent in the outer Dynean arm, and here is a normal control. You can see a nice overlay of the two. Whereas in this case, there is no overlay of this second protein, and this is a positive case. In fact, this is a case that was positive by genotype as well. And here we see an even more clear example, that there's just absolutely no red fluorescence in the patient sample compared to in the control. So there's now a battery of about 5 or 6 antibodies that have been developed. Only a few laboratories are doing this. The Brigham is actually very interested in this and have started to do some of this work. And it looks like it's a technique that could be very helpful off of a biopsy, and potentially much better than EM. Because in some of the cases that actually have defects that we should be able to see on EM, you don't see them, but they pop up really nicely on the immunofluorescence. You can see that it's not perfect, but it's good, and it's not too expensive. And then that brings us to sequencing. I will be talking very briefly about video microscopy later in a different setting. It's actually interesting that we're having the optical CT person, because I'll be talking about that a little bit. But what's being used in Europe a lot is video microscopy, high-speed video microscopy. It's basically not available in the United States. Maybe in one center. It's not really been embraced. So moving to sequencing. With the advent of next-generation sequencing, we can now run, at a relatively modest price, all of the genes that have been identified in PCD to date. This is a slide that's slightly outdated with respect to the myriad of companies that are now providing testing. But what I would say, and I don't get anything from Invitae, and I helped develop this panel, I would go with the Invitae panel right now for 2 reasons. One, it currently has the most number of genes. It covers essentially all of them. There's about 37 genes on the panel. You also get CFTR. And what's really nice is Invitae is really trying to corner the market for sequencing in general. So they have genetic counselors that will go out and draw the bloods. They send kits out if they need to, and they set a cap of what the patient is going to have to pay maximum. It's about $400, even if it's refused by insurance. So it's very hard to compete with that. So we send, if we're only worried about PCD, we only send off the Invitae panel. If I'm concerned about a differential diagnosis, including pulmonary hypertension genes or sometimes pulmonary fibrosis, then I'll use the molecular medicine test, the Pulmogene panel, because we also get the fibrosis genes, we also get the pulmonary hypertension genes. So it all depends on what my level of clinical suspicion is. But here's an example. This was actually the second patient that we ever saw at the Pulmonary Genetics Center. You put up a shingle saying you're a Pulmonary Genetics Center, patients come out of the woodwork. So this is a woman who is 42 years old, had been diagnosed with asthma, and had gone through a diagnostic odyssey over about 30 years of trying to get diagnosed for why no one can understand why she's got such bad lung disease. And that included getting an EM biopsy that was negative, and it included getting a bronchoscopy with a biopsy resulting in a pneumothorax, and utter frustration, and about $25,000 worth of her own expenses over the years trying to figure this out. Now, I had the luxury of having this history and having had all this stuff done, but I also had the luxury of having our panel. And I said, we're going to do one test. We didn't have nasal nitric oxide yet. I said, we're going to do one test. We're going to sequence you for the known genes. And in one test, for $2,500, she had 2 pathogenic mutations in one gene. The asterisk variant is very interesting. It's only been described once before in a Swiss family, and she's of Swiss ancestry, so she's somehow distantly related to that other patient. Diagnosis done. Non-invasive test. And very comprehensive. It covers about 75% of cases today. So the issue today is not the accessibility of this or whether it's worthwhile doing genetic testing. And when people talk about the expense of it, it's an absurd thing. Because if somebody comes here and I do pulmonary function testing on them and they're from out of network, the PFTs are $3,000, okay, for a set of PFTs. So to get a genotyping, sequencing for $2,500 to make a diagnosis, I don't think is really something to complain about. The issue is interpretation, okay? We don't have time now to go into how to interpret every single gene, but the bottom line is what you need to see are 2 pathogenic variants. So a positive test is 2 known pathogenic variants. Unfortunately, most patients have private mutations that haven't been seen before. So you have to suspect as to whether or not it's pathogenic. And so you get into this whole problem of variants of unknown origin or unknown significance. Okay, and so that's a bit of a problem. The big thing I want you to be aware of, if you do go ahead and order this on your own, and I highly suggest that you just get in touch with us because we have a genetic counselor, we'll help you interpret things. We're more than happy to help you with this. You'll get back a report that'll say there's a pathogenic variant in this gene and there's another pathogenic variant in this gene. And you're going to want to say, oh, this is so cool. It's an interaction of 2 genes. Don't buy it. The likelihood that that is true is very, very low. First of all, it hasn't been described yet. And we're all looking for it. And yet there's no demonstrable functional readout that has ever proven that that's the case. So don't interpret it that way. Okay. These are the recommended guidelines. I'm going to skip over this. We've gone over this already, but you can see that it kind of changes with age. And I'm going to skip over just to say, remember when you're working up someone with bronchiectasis that it's not all genetic. You have to, of course, rule out all of the environmental causes, all of the other immunodeficiencies, large airways disease. But when you come down to it and you've got somebody with idiopathic bronchiectasis and you've excluded these other things, PCD is a very reasonable thing to rule out, even if they don't have some of the other features. What they should all have is nasal congestion. If they don't have nasal congestion, they probably don't have PCD. Probably. But what I want to end with is 2 quick things. The first is how I think we need to start thinking, not only in PCD, but in medicine more broadly, about thinking about changing the paradigm of how we do diagnostic workup when it's appropriate to do so. And what do I mean by this? In the classic paradigm, we go from history and physical and basic laboratory tests to then getting supportive laboratory tests, and then we say, okay, let's confirm this with the genetic testing. And I'll give you an example in a moment. I think we need to start flipping this on its head. That if we think from the history and physical that genetics could be a part of this, it might be worthwhile to do the genetics a little bit earlier. So let me give you an example. If we do the classic paradigm here, when we think about bronchiectasis, the major genetic differential diagnosis is alpha-1 antitrypsin, cystic fibrosis, and PCD. You do sequencing. The sequencing costs are falling. Let's say it's going to cost us $1,500 to get this. So the normal way you do it is you would first get serum levels of this, you'd do the sweat chloride, you'd get the nasal, and then you'd say, oh, I've got one of these, I'm now going to do testing, and I'm going to do sequencing for each of these different things, and it actually costs a lot of money to do that, except for the alpha-1. What I'm saying is maybe for some of these disorders, we need to start thinking about doing it a different way. That we first do the sequencing for the $1,800, we find that the person has a PiZ genotype, and then we can get the levels to confirm that, in fact, that's what's causing their problem. Similarly, we would get CFTR sequencing and then do sweat chloride. And similarly for the PCD, we would then get the NO and confirm that this is the phenotype. Now, the reason not to do this, okay, is that you might end up doing a lot more sequencing that you would need to do, and you might be going down some rabbit holes if you don't know how to interpret the data properly. So I'm not saying we should do this today, or at least not everybody should do this today. But many people don't have access to nasal nitric oxide. They wouldn't otherwise be able to make the diagnosis. They don't have access to any of this, whereas the blood test can be sent from anywhere in the world, and they'd get back the result. So with time, as the prices fall and the indications increase, this is going to become a bigger and bigger thing. So management, I'm going to just briefly say, you want to maximize airway clearance, and you want to do it however you can, and you want to start it as early as you can. A really important thing is that PCD kids tend to go through a little bit of a honeymoon when they hit their late teens, and they stop using their stuff. And what's recently come out in a number of different ways, and our genetic counselor, Nicola Carmichael, is actually doing a thesis on this for her PhD, that adolescents and young adults realize that one of the ways they can keep their mucociliary clearance up on par with what they were doing before without having to actually do it is exercise, particularly jumping and running activities. And so we highly encourage our patients to take up sports and run and so on, and it's as effective as if they use the flutter valve or the vest. Again, this isn't the case for CF, because in PCD, you don't have this viscoelastic barrier to overcome like you do in CF. The microbiology is very similar to CF. I don't think there's anything really to say here. And I'll just end with saying, in terms of future directions, I had a few more slides I was going to show, but to say that, one, we're very interested through our precision medicine initiative to really drive this idea of a sequence-first approach and see how helpful it can be. That's number one. Number two is we're working with Gary Tierney at Mass General and with Steve Rowe and George Solomon and University of Alabama to look at the use of micro-OCT to be able to do both in vivo and in vitro functional testing of cilia to see whether or not they have a ciliopathy. So here's what this looks like. You have a healthy control where you take the cells, you just do a nasal brushing. You don't do a biopsy, you just brush the nasal cilia. Oh, let me go back one. So you brush the nasal cilia, you plate them, and then you use this form of micro-OCT to video it. And you can see a very nice movement to the cilia here. And this is one of our PCD patients, not moving at all. Okay? We sent them blindly to University of Alabama a whole bunch of cases that we thought had PCD, but we didn't tell them what they had. And we also sent a few controls. And you can see that all of the patients that we thought had PCD had one of different quantitative measures of ciliary dysfunction that come off of this micro-OCT that were abnormal, including the arrow is that patient I told you about that was hugging the nasal nitric oxide line who has a normal EM and we don't have mutations in yet. She is clearly behaving with most of her phenotype like a PCD case, although for some of these measures, it's actually very similar to controls. So she's got a new phenotype, we think, and she'll end up having mutations in something that hasn't been identified before. So we have a lot of different things going on. We're involved in a clinical trial, but just to say, the summary here is think PCD. It's not a benign disease. I'm sure there are a bunch of asthmatics that are being misdiagnosed all the time with this, and that we're here to help with this in any way we can. Huge number of people to thank, and just for the sake of time so that we can maybe take a question, I'll just leave this up. So thanks for your attention.
Thank you very was fantastic. Thank you. Yeah, ready for questions.
Dr. Raby, that was phenomenal.
Thanks.
In the infants who were born with heterotaxy that are I believe some of them, not all of them, can be diagnosed with an ultrasound prenatally.
Okay.
I don't think.
Yeah, no, definitely the heterotaxy can be diagnosed pre-birth.
I remember seeing that when I was in the delivery room, seeing that.
Yeah.
Is PCD genetic analysis part of the polysomnia or heterotaxy workup at all?
Right. So now that sequencing has, so in the neonatal period, you can't use the nitric oxide, right? And no one's going to do an EM biopsy that quickly on a neonate, particularly if it's not going to really make a difference in management over the first few months of life. So genetics would be the way to go there. And now that we have that, that would in fact be the thing to do. So if, I'll put this up while we're talking, if we go to the diagnostic criteria, the recommendations for diagnosis, you'll see that in every age group, biallelic mutations is one of the criteria to make a diagnosis. So if you confirm two mutations, you're done. You don't have to do the nitric oxide. You don't have to do an EM. It's a diagnostic criteria accompanied by the symptoms.
You mentioned that there are about 35, 37 identified genetic abnormalities that affect ciliary function. Do you have a guess as to how many actually exist? What portion of the true number of genetic influences on ciliary function have been identified today?
Okay, so it's a very important question. So there are 90 genes that have already been described as part of ciliary function. There are different types of cilia, as we mentioned. There's a lot of types of kidney disease that are actually ciliopathies. And those patients typically don't have any pulmonary phenotype because the mutations are in different parts that aren't really relevant to the respiratory epithelium's function. So we know of about 90 genes related to ciliary function, of which 35 are attributed to respiratory ciliary function. That accounts for, we think, about 70% of cases. So we're looking still for 30% of cases, but we don't know how many genes it'll take to get there. So you might think, well, if it took, you could do like a back-of-the-envelope calculation and say, if 37 genes got you 70%, then you could figure out how much would get you to 100%. But in fact, genetics really doesn't work that way because the rest could actually be one-offs in many, many cases. They could be private mutations in one or two families, and you won't see it again. I was just talking with someone in retinal degenerative disease, okay, which is the most common forms of genetic blindness, retinal degeneration. There are now 295 genes that a mutation in them have been described as causing retinal blindness. The first 20 of them describe the majority of cases, but then you've got all these others. So what's going to have to happen, I think, is we will get to a point at which it's going to be a one-off, and so we need to have better understanding of what the reference genome looks like, which mutations to be clued into, and that requires a lot of bioinformatics, and that's what a lot of the precision medicine work is focused on, and a lot of groups are working on these types of things, not only for PCD, but for all genetic diseases.